Welcome to the Red Med podcast, Rescue, Expedition and Disaster Medicine, where we provide a platform for healthcare professionals working in or aspiring to join rescue, expedition and disaster response teams. A platform to share information, advice and opportunities and connect like-minded Red Med individuals in our community.
Good afternoon and welcome to the Red Med podcast, Rescue, Expedition and Disaster Medicine. As usual, this podcast is sponsored by SOS Coffee which we sell to fund medical missions for underserved communities in Guatemala. It was fantastic to speak to a lot of you out in the Wilderness Medical Society conference over in Spokane last month, and a lot of you expressed interest in coming down to do the Red Med course and specifically to help out on the medical missions. So thanks for your interest, thanks for buying the coffee, and more details will be coming out soon about that medical mission next May. In addition to the coffee, the proceeds from my book, Dengue, A Guide to Prevention, Diagnosis and Field Treatment, also go to support the medical missions and our communities down in southwest Guatemala. Today, as the title suggests, I'd like to talk about dengue. The podcast might be useful for risk managers, expedition leaders, expedition medics, humanitarians, anybody travelling to any of the over 100 countries around the world where dengue is endemic at the moment. And it might be useful to create awareness, to complement your risk strategy or your risk mitigation strategy to prevent dengue in your team or your operation. But why is it important? Let's look at some of my personal experiences and then look at some of the serious statistics in the literature at the moment. So aside from being an unwelcome febrile illness that might result in one of your teammates becoming bedridden for a week, or just confusing a differential diagnoses and creating chaos because of the non-specific symptoms, cases are generally on the rise globally, as are deaths from severe dengue. My own experience, there are three distinct experiences that stand out. The first being bedridden with fever and achy bones in a hotel room in Nepal following an expedition to Everest Base Camp. There was an outbreak in Kathmandu of about 35,000 cases. At the time, I'd been bitten on arrival back from the Khumbu and succumbed to all of the classic signs and symptoms. Secondly, I was responsible for the mitigation of dengue whilst on a film set in a tropical country. We had a crew of 800 people and we're filming on a set in the rainy season, surrounded by shallow streams, ponds, pools, tyres filled with water. And there was an outbreak of dengue at the time where we were shooting. So that was a full team effort to try and mitigate the spread of dengue amongst the crew. And then ultimately, but most memorably, was following a medical mission in Guatemala. We had an international team of allied health professionals volunteered, plus a lot of guys from my company, SOS Medical Services, a lot of the volunteer fire service, helping the community with everything from dental hygiene, water treatment education, ironically, mosquito-borne disease mitigation, as well as providing primary care services. They did a phenomenal job. Just as we were closing up, we just closed the last Pelican case, loaded everything onto the back of the pickups and the ambulances. Then a father walked over the brow of the hill with his unconscious 12-year-old boy in his arms. We assessed him. He was disoriented. He hadn't eaten or drank for the best part of 5 to 7 days. He had no radial pulse, hypotensive, going into shock, and on closer inspection he had a temperature of 39 degrees and he had epistaxis and bleeding from the gums. classic hemorrhagic dengue, or what is now known by the World Health Organization as severe dengue. We gave him a bolus of fluids, antipyretics, quickly transported him to hospital, where he received a blood transfusion and made a full recovery, thankfully. I don't think his parents realised the gravity of it, nor did they have the finances to get to hospital or to buy the medications. And I think Javier would have probably died. Fortunately, he didn't. The guys that were working with us picked up on it quickly. But ultimately, it really sends a message that prevention is extremely important, as is early recognition and treatment of dengue. So dengue is currently endemic to over 100 countries worldwide. In the Americas alone, there were 2.5 million cases in the first 40 weeks of last year. Some regions of the Americas have had up to 251 cases per 100,000 population. Again, in the Americas, there were 3,645 cases of severe dengue reported, with 1,130 deaths. The European CDC reports that mosquitoes responsible for the transmission of dengue have established themselves in 13 new European countries. But I think more specifically, this year, there have been 3 large-scale outbreaks, or rather the back end of last year. In Kathmandu, there were 35,000 cases of dengue in the city, with 38 confirmed deaths. In Peru this year, there have been 146,000 cases reported, with 248 deaths. And then more recently in Argentina, there's been an outbreak of 60,000 infections and 40 deaths to date. In a recent study by the London School of Hygiene and Tropical Medicine, along with the University of Oxford, the study results forecasted that 60% of the world's population will be at risk of contracting dengue by the year 2080. Driven in part by changing weather patterns, climate change, urbanisation and increasing population density, we're likely to see dengue creep into our missions more and more. And so we're really going to present information about prevention, how to keep teams safe, the personal, the team, the operational and the community preventative measures, along with some of the signs, symptoms and the treatment of dengue. So what is dengue? As most of us know, it's a mosquito-borne febrile illness caused by one of the 4 dengue RNA viruses, namely Denve 1, 2, 3 and 4, or dengue virus 1, 2, 3 or 4. There are reports in the literature of a 5th serotype having been identified, but the literature is scant at the moment, so we're going to focus today on the 4 common serotypes. But ultimately, it's a vector-borne disease spread from person to person by infected mosquitoes. Transmission usually from a bite from an infected mosquito, and usually through the Aedes aegypti or the Aedes albopictus species. It is possible, however, to contract dengue from blood transfusions through unscreened blood infected with dengue. And this might pose a risk to teams operating far forward that are considering utilising walking blood banks and using unscreened donors, or if the donors are operating in areas with endemic mosquito-borne diseases. Formerly known as dengue fever and dengue hemorrhagic fever, in 2009 the World Health Organization reclassified the terms, and the new terms are now dengue and severe dengue. It's useful to understand when we're travelling what the life cycle of the mosquito is and the elements or components that they require to survive, thrive and continue to infect people. Ultimately, the Aedes albopictus and the Aedes aegypti mosquito required 2 components: shallow water in which to lay their eggs, and invertebrate blood, which is how they feed and how they transmit the disease. So unlike other species of mosquitoes that prefer deeper, nutrient-rich water, the Aedes mosquito prefers shallow, stagnant water. So shallow, stagnant water sources such as shallow pools, blocked rain gutters, water-filled plant pots, pet bowls, bird baths, rain barrels, all of these kind of things are prevalent during the rainy season and present the ideal habitat for the Aedes to lay their eggs and continue the life cycle. Things like rivers, fast-moving streams or deep ponds pose less of a risk. And as we mentioned, we're going to see an increased likelihood of outbreaks during the rainy season. And unlike malaria, which is often seen in rural areas, dengue is quite often prevalent in urban or suburban populations where there's a dense human population along with shallow water sources. Again, in the tyres, in gutters, plant pots, provides the perfect environment. Prevention. Prevention is key, but why is it important? Most people, when bitten by an infected mosquito that develop dengue, will be asymptomatic. Some people will go on to have febrile illness, and we'll talk about the signs and symptoms shortly, but ultimately most people are asymptomatic. Following that initial infection, the patient will develop long-term or lifelong immunity to that same serotype, to the same dengue virus. But it does not confer immunity to any of the other three serotypes. And therefore, sequential or subsequent infection with another serotype significantly increases the risk of contracting severe dengue. So prevention is key. There is a vaccine available. There are several vaccines in circulation and under development that are approved and available in about 10 to 20 countries worldwide, but they are generally only available for at-risk groups and for anybody that has had laboratory confirmed previous infection. The vaccine only provides protection against severe dengue for people who have already had a confirmed case of dengue. Anybody that was to be vaccinated that hasn't had dengue, then the vaccine may serve as the first infection, and therefore they may be at increased risk of severe dengue during subsequent infections. So prevention is key. And prevention is often through a layered approach. It's no use just putting on insect repellent and hoping that you'll be safe. There's a whole ecosystem of interconnected actors that we need to consider. So the layered approach should really consider personal prevention and protection, a team approach, a local environment or a camp approach, and then a larger, wider community approach. So individually, on a personal level, we can avoid wearing shorts and t-shirts, avoid exposing our skin. We can wear light-coloured, long-sleeved clothing, long trousers to prevent mosquitoes landing on us and biting the skin. Utilisation of repellent. DEET is without doubt the best in the literature, but if anybody prefers a natural approach, then there is good evidence to suggest that the natural lemon eucalyptus is the most effective natural repellent. It's on par with DEET, certainly for the first 4 to 6 hours. Sleeping in mosquito nets treated with permethrin or some other insect repellent are very, very useful to prevent bites, but do consider local laws and any local resistance to permethrin. It may be that permethrin is banned, as it is in Thailand, or there is local or regional resistance and other chemicals might be recommended. Removal of standing water sources is key. A couple of centimetres of clean water is the perfect breeding ground for the Aedes mosquito to lay their eggs and continue the life cycle and contribute to a whole host of mosquitoes within your operational area. So empty out tyres, empty out the water from plant pots, try and remove the water from any buckets, baskets, set up camps away from shallow ponds and pools. And then ultimately, if there's any water sources that can't be eradicated, then you can consider treating the water with larvicides or insect growth regulators. A common larvicide is BTI, or the BTI bacteria, and I want to give this pronunciation a go. Bacillus thuringiensis israelensis, or BTI for short. Ultimately, it's a naturally occurring bacteria that comes in granules or tablets and is added to the standing water to kill mosquito larvae. It's thought to be harmless to humans and other aquatic wildlife. Simply add the correct dose of tablets or granules, it dissolves in the water and interferes with the growth of the larvae and significantly reduces mosquito populations in the area. But ultimately it should be a two-pronged attack. We're looking at reducing the larvae in the water sources and then also the population of adult mosquitoes in the area. So space spraying, fumigating or fogging is useful, and that can be done with insecticide or adulticide to kill the adult mosquitoes in the area that often hang around in dark shaded corners, lofts, foliage, piles of duffel bags. And there's two different systems really. There's thermal foggers that use gas canisters to heat the coils and generate the fog. They're best for outdoor use or very well ventilated spaces. And then there's cold foggers, which are often battery operated or plug into the mains, and they're generally safer for indoor use. On a more local level, you've got spatial repellents such as mosquito coils that you ignite or plug-in devices. Likewise, simple things like air conditioning or turning on fans will circulate the air and potentially increase the airflow and push the mosquito away from you so they can't land and bite you in the night. If your budget allows, there's a fantastic trap, a mosquito trap called the mosquito magnet. I've got no commercial affiliation to these, but I have used them in tropical countries. And this is a large device that runs on propane gas, and the machine essentially converts the propane to CO2 and heat and attracts and traps the mosquitoes within about a 200-foot radius. So extremely effective, but slightly more expensive than your repellent or mosquito nets. So it really comes down to the combination. We need to be looking at personal protection through insect repellent, appropriate clothing, covering up skin, sleeping in mosquito nets, and then a team and a camp approach, siting the camp away from shallow water, removing standing water or treating it, daily fogging either around the camp or prior to your daily activities, prior to patients turning up for medical missions or prior to filming if you're out on a shoot. And then look at the broader community. If there are cases of dengue in the community and there are community members affected or infected and they come to work as film extras or they come to your clinics, then if there is a mosquito population, they can bite the infected community members, bite your team members, and continue this cycle of infection. So we need to really think about our risk mitigation should be broader and encompass the local community. So let's get involved with the local leaders, look at the local epidemiology, look at potentially educating the local populace, or can we donate insect repellent or mosquito nets to the at-risk population? In practical terms, out on the film set in a tropical country during the rainy season, this would really mean a full-time job for the team. The team would arrive on location about 3 a.m. They'd walk around the set or the location, emptying pots, pans and tyres from the previous night's rain. They would accompany the snake wrangler around to check the locations for any unwanted guests, and then ultimately fog the huts, bushes, drains, stores, baggage areas, kitchens, leaving ample time for the fog or the insecticide to dissipate before the crew arrived. Interestingly though, rather than just eradicating mosquitoes, everywhere we fogged, it used to seem to drive the snakes out into the open. And we found boa constrictors and tree vipers all over the shooting location, which delayed shooting on a couple of occasions. So after fogging, the team would wander around, checking the mosquito magnet traps, making sure they had power, sufficient propane gas, were sighted correctly based on the wind direction, shooting location. So it's a fairly dynamic job. They would have to move the traps as the wind changed or the shooting locations changed. And then following the daily preparation, following the fogging and eradication of the standing water, the team would stay on set and accompany the film crew all day, offering insect repellent, clearing out any other standing water as it rained, and then any other sources they would treat with BTI. In the background, I would meet with the Ministry of Health, and their delegates would collect mosquito samples from the site, taking them back to the lab to determine the species, and then testing for pathogens such as dengue, Zika, chikungunya, Japanese encephalitis. And I'm pleased to say they didn't identify any on the location, but it was an ongoing process. So BTI, lots of questions surrounding that. Is it safe for the environment? Is it safe for other aquatic life? And the CDC have produced a simple fact sheet on BTI that you can access on the CDC website. But certainly, if you're responsible for fogging with insecticide, it's worth taking a good look at the MSDS, the Materials Safety Data Sheets, as the insecticide can be harmful, can be irritant on the skin, the eyes, the respiratory tract. So do work with experts, have a look at the MSDS, and ultimately make sure that the fog has dissipated before the crew arrive to start work. Let's take a look at the phases of dengue and some of the signs and symptoms and the diagnostic criteria. So the incubation period is 5 to 7 days, and quite often patients will develop a fever between 39 and 40 degrees. The disease generally consists of 3 phases: febrile phase, the critical stage, and the convalescent stage. Usually identified through 2 or more clinical findings. The symptoms you might expect to see could include that classic fever, 39 to 40 degrees Celsius, headache, retroorbital pain is a common complaint, muscle and joint aches and pains, bone pain. Dengue used to be called break bone fever because of the severe pain in the bones and the muscles, macular or maculopapular rash, and potentially a positive tourniquet test. So what is the tourniquet test? Ultimately, it's to identify capillary fragility. It's a useful clinical diagnostic method to determine a patient's hemorrhagic tendency or status and potential for thrombocytopenia. And it's an accepted diagnostic tool as cascaded by the World Health Organization. Very simple procedure. Place the blood pressure cuff around the proximal arm, inflate the cuff to midway between the patient's systolic and diastolic pressure. Keep the blood pressure cuff inflated for 5 minutes. At the end of the 5 minutes, the blood pressure cuff is removed, and if there are more than 20 petechiae in 1 square inch of skin, that is classed as a positive test for severe dengue. So they're the standard signs. Then we've got warning signs of the potential for development of severe dengue. So warning signs could include abdominal pain, persistent vomiting, anorexia, clinical fluid accumulation, and possible hypotension. Severe dengue, we're looking at a history of the clinical findings over the previous 2 to 7 days, evidence of plasma leakage, evidence of shock, hematemesis, bloody stool, bleeding gums, epistaxis, respiratory distress, and altered mental status. So, how do we diagnose it? Can we diagnose it? We're looking at the clinical findings contrasted with the incubation period, evidence of bites in a dengue endemic area, presenting with 2 or more of the clinical signs. We would potentially assume it's dengue. Likewise, there is a PCR test for dengue, or there is an NS1 antigen test, which is best done in the first week since the onset of symptoms. And then in the second week since the onset of symptoms, there is an IgM antibody test. Very similar to the COVID antigen and antibody tests. They're cheap, disposable, and readily available in endemic regions such as Southeast Asia and Latin America. So it is a non-specific febrile illness, easily confused, potentially confused with flu, malaria, Zika, chikungunya, COVID, to name but a few. So it's useful to keep an eye out on the local trends. Is there an increase in local outbreaks? Are there an increase in local cases? Have we got appropriate mitigation measures in place to prevent that cross-infection through the dengue mosquito vector? And ultimately, if we can't diagnose it through the clinical symptoms, the incubation period, etc., then perhaps we can employ an NS1 antigen test, or at the right time an antibody test. Or if you can get out from the remote areas and get to a lab that can do dengue PCR tests, then that might be useful to rule in or rule out other pathology and specifically direct treatment. So what is the treatment for dengue? Ultimately, there is no specific treatment. In dengue that presents with flu-like symptoms, the core treatment is hydration and paracetamol. Paracetamol is useful antipyretic. Likewise, it can help with the muscle and bone aches and pains. But the key here is to avoid drugs such as aspirins or other non-steroidal anti-inflammatory drugs due to their anticoagulant properties, which could potentially exacerbate any bleeding. One consideration when we're employing prolonged field care is to avoid exposure of the febrile patient to mosquitoes to prevent onwards transmission to other team members. So if you do have somebody in a remote area with a fever and you suspect dengue, whilst we're monitoring them, checking on them, arranging evacuation or laboratory tests, they should ideally be resting inside a mosquito net, so any local mosquitoes can't bite them and then go on to bite another team member and continue that chain of infection. So general supportive treatment for dengue, and then if there are any signs of warning signs or severe dengue, then really it's employ the medical emergency response plan, best medicine being diesel, and get off to the ICU so they can be tested and provided with supportive treatment and continual monitoring in hospital. So in summary, I think any group travelling overseas to not necessarily remote areas, because dengue is prevalent in the urban and suburban areas, not necessarily the deep tropical rainforest, it's useful to do the research prior to heading out into these areas. And as we always do, look at the current medical threats in that specific area, look at the current endemic diseases, any areas of specific outbreaks, the season, the time of year, any specific threats that we can identify through local reconnaissance, speaking to local leaders, the Ministry of Health, identifying potential filming locations, campsite locations. Are there any potential static water sources or standing water sources that we can eradicate? Or if we can't, can we identify local suppliers to provide larvicides, BTI, local contractors to support with spray spraying, fogging or fumigation? Have we got appropriate DEET, insect repellent, appropriate clothing with long sleeves, long trousers to cover up the skin, mosquito bed nets to protect ourselves, community initiatives to look at the wider community and perhaps how we can support the community and break the life cycle around the community and ultimately have the community serve as an extra layer of protection for our team, and likewise our team can serve as a layer of protection for the local community. So that layered approach of prevention is really important and certainly requires a little bit of forward planning rather than just turning up on the ground and trying to cuff it through ad hoc measures. Hopefully that short introduction was useful to present the expanding scale and scope of dengue, the life cycle, some of the preventative strategies and the layered approach, along with some of the signs, symptoms and diagnostic tools of dengue, along with the treatment and when to seek support. Hopefully that will help you to plan any future missions and mitigate any potential patients in the future. If anyone's interested in further reading, there's the Dengue, a guide to prevention, diagnosis and field treatment, which is available on Amazon. And again, all the proceeds from the sale of that book go back into our medical missions and help us to provide mosquito nets, insect repellent and testing kits for our communities down in southwest Guatemala. And the next medical mission will take place in May 2024, following the REDMED course, the Rescue Expedition Disaster Medicine course in Guatemala, where we will be rafting through the jungle, setting up jungle camps, jungle survival, trekking a high altitude volcano, and travelling through the land of eternal spring, or Mundo Maya. And those of you that want to stay on for a couple of days at the end can help out with a medical mission. We're reaching out and appealing for support from all allied health professionals, anyone from EMTs through nurses, PAs, paramedics, doctors, dentists, surgeons. The communities need your support. So if you want to do the REDMED course, please do get in touch. And if you need to head straight home, that's cool. If you'd like to stay in Guatemala, you can stay and join us for a couple of days at the medical mission, raft through the jungle, get to the community, and then we'll be involved in everything from dental care, primary care, to helping the community understand the different methods of water treatment. And then we'll be employing different workshops to help mitigate mosquito-borne diseases. But before that, in October, November this year, 2023, we've got the REDMED course in Nepal, and we'll be employing the flipped classroom approach. So there's a period of online self-paced learning so that when you arrive, you can thoroughly enjoy the Khumbu Valley and the incredible views of the 8,000ers as we trek towards Everest Base Camp, having team discussions around the fire pits in the tea houses, and then employing skills and scenario-based training in context in the shadow of Everest at Everest Base Camp before going on to do a mountaineering training day and attempting a climb on a 6,000 metre peak, namely Lobuche East at 6,119 metres. So all the way we'll be talking about patient assessment, altitude sickness, hypothermia, frostbite, prolonged field care, patient packaging, helicopter safety, communications, telemedicine, medical emergency response planning, risk assessments, fractures, analgesia, all of that kind of good stuff, supported by the REDMED faculty and our incredible climbing Sherpas, who between them have got numerous ascents of Everest and K2. So if that sounds like fun, if that sounds like you, do get in touch. There are still spaces on the October course. And if not, we've got the UK-based course coming up in February 2024. And we'll be looking at topics such as disaster medicine, helicopter safety, mountain medicine, search and rescue, heat, cold, bites, stings, and an awful lot of the non-clinical competencies such as mission planning, obstacle crossing, etc. Anyway, guys, thanks for tuning in. Thanks for listening. Thanks for your support. Wherever you are in the world, stay safe and hope to speak to you soon. Bye-bye.